Hey everybody, just got some ventilator and BiPAP scenarios. I'm just going over a few things. This is kind of a little second part to the ventilator BiPAP video that I had done. So let's get started. So we're here to talk about vents, PEEP, CO2, you name it. And memes are always the best thing to do to get your point across. Alright, so just food for thought as a reminder. FiO2, PEEP, and I time are usually what you go to for your PaO2 issues. Tidal volume, expiratory time, rate, which, minute ventilation will help fix your CO2. And you always want to consider the baseline when making your ventilator changes, because for patients, let's say, that have COPD, giving them a perfect blood gas isn't necessarily going to benefit them, especially if their baseline CO2 is in the 50s and you put them down to the 40s or low 40s, like a normal number. You're not helping them get back to where they are, because if you expect that and then once you extubate them, they're just going to, go back to, the original or, So why do we always want to look at IE ratios? It affects expiratory time. And, there's not necessarily one right answer. It's always a discussion. And if you're using this in a classroom setting, just definitely feel free to pause and discuss it and what you would do. And I can give my rationale. And if, someone has a different rationale, I'm always willing to listen. And and there's always definitely more than one combination that's going to be right. So case study number 1, we have a 68-year-old man with a history of COPD, comes into the ER complaining of shortness of breath. He's extremely diaphoretic and tachypnic, and he only speaks in phrases. There's his initial blood gas on a non-rebreather. He's intubated. Those are his vent settings. And then 1 hour after intubation, draw an ABG, and that's where we're at. So what's the best thing to do for this gentleman? So what would Matt do? So my train of thought would be to increase his rate to 24, increase the PEEP, and then drop his I time to 0.9. Just drop blood gas in 30 minutes and just see where you go. You don't always necessarily need a perfect ABG because it's just not beneficial for this gentleman. BiPAP's always a consideration, but with the 7.1 initial pH and the tachypnea, he was probably already in, hypercapnic respiratory failure, and chances are the BiPAP wouldn't have worked for him. The last guidelines I read, 7.2 is kind of the lowest you should go. I've seen lower. Sometimes it works, sometimes it doesn't, but usually when they get to that point, there's probably something else going on. So number 2, a 75-year-old woman with a history of CHF comes into the ED complaining of shortness of breath. She's got a productive cough with pink, frothy, watery secretions. That's her ABG on 4 liters. The attending physician is in the trauma bay dealing with another golf cart accident from the Villages. What do you recommend? So for these patients, generally, I put them on a CPAP from 8 to 12, 40 to 50% FiO2. Sometimes, if you need to go higher to maintain SpO2, then you got to do it for the time being. And then, usually, 40 shot of Lasix to get them peeing is usually what's going to benefit them. If they're not able to make urine or they're a hemodialysis patient, you're going to have to hurry up and get them up to the dialysis unit so that way they can get some of that fluid off. I've seen patients that have come in CHF, exacerbation. They put a Foley in them, put them on CPAP, and then give them some Lasix, and they've peed out 2 or 3 liters, and by that afternoon they're going up to the floors on a 3 or 4 liter nasal cannula. So just so you know, if you got bad handwriting, there's hope for you. So 45-year-old female comes into the ED with an exacerbation of myasthenia gravis. NIF and peak flow meters have dramatically decreased over the last few hours as per respiratory. What's your next step for this one? So this patient is probably going to end up intubated just because of the decline in their peak flow and NIF numbers. And the myasthenia gravis is slowly causing a paralysis of the diaphragm. And usually you just want to intubate as an elective thing before it becomes an emergency. A lot of times these folks that do have myasthenia gravis or Guillain-Barré, if they've been through this before, they kind of know, like, hey, this is where you're heading, and they know. So number 4, we have a patient who's been intubated for the past 3 days. The original complaint has resolved, so they're currently on pressure support 12/8 at 40%. After morning rounds, you're going to put them on an SBT 5/5 for 30 minutes. We get weaning parameters, and here's what we got. What do you think we should do? Let's extubate. Drop the cuff and pull the tube. Put them on O2, preferably humidified. Intubation, extubation, I mean, that's fairly traumatic to the airway. Cool mist can help with inflammation. You always want to make sure that stridor is not an issue. And then when they start feeling a little better and, in the next few hours, get them coughing, deep breathing, and, work on getting them out of the ICU. A lot of these folks are going to have secretions, probably fairly plentiful in the few hours post-extubation. And that's usually what we do. So, number 5. So the patient comes into the ER after being assaulted. Mandible, maxilla, left orbital socket, along with multiple ribs are fractured. He's having trouble breathing. Starting to look diaphoretic with intercostal movements. What is the best thing to do for him? Well, first, if it's pain, pain meds might help. If not, could it be anxiety? If not, probably end up intubated as, facial trauma is contraindicated for a BiPAP or CPAP mask. If the patient requires surgery, they're probably going to do a trach so the jaw can be wired shut and the surgeon can fix any other issues that could require surgical intervention. So a 34-year-old male comes in with burns on his arms, chest, and legs, and he's starting to have respiratory issues. You notice his face is cherry red, his nose hairs are singed. What is the next course of action for his airway? So this is kind of a big deal. For these folks, you generally want to intubate them right away. He's probably got airway burns, and with burns comes swelling. So a swollen airway is never a good thing. So you want to hurry up, get them intubated. So if he does swell, you'd rather have them swell around an artificial airway as opposed to his trachea, which will swell shut. And then you end up with a bigger issue at hand. And then you probably would want to do a bronchoscopy to get a visual of the inside of the bronchi. Chest PT if they're able to tolerate it, suctioning, and then also serial bronchoscopies are not uncommon, especially when sloughing starts to happen and you don't want the airways to plug off and the patient go into a respiratory arrest. So sometimes you just got to look on the bright side. So case study number 7. A 19-year-old female comes into the ED post-MVC. She was an unrestrained driver with shortness of breath and chest pain. After exam and x-ray, she's got 7 broken ribs with tachypnea. That's an ABG on room air. What's the best course of action for this patient? Initially, you probably could just put him on a nasal cannula. And with the decrease in tidal volumes, it can lead to atelectasis and eventually pneumonia over the course of days. You can use CPAP and do what's called pneumatic intercostal stabilization, and it just helps stabilize broken ribs and by inflating the lungs and keeping them moving less than what they were previously. And it can sometimes help patients be a little bit more comfortable, but then you run into the common things about people wearing masks and stuff like that. So intubation for these people aren't necessarily out of the question either. If only that doctor was Ryan Gosling. All right, number 8. The patient is placed on BiPAP after coming in with COPD exacerbation with hypercapnic respiratory failure. 14/7, 50%, and that's what we have on his ABG. How would you like to manage this patient? So first things first, the patient's PaO2 is below 60, so we can probably make that a little better. I mean, you're probably not necessarily going to need them get to a PaO2 of 80 or better, but you know, a little bit above 60 is more tolerable. Increase EPAP FiO2. The pH is pretty acidotic. If you're going to adjust EPAP, you also want to adjust the IPAP as well. So on most BiPAP machines, you know, you subtract your IPAP from EPAP, and that's your delta P. So in this case, the delta P is 7. So let's say you increase the EPAP to 9, and you want to have a bigger delta P. I would push the IPAP to like a 19 or something. If they can still tolerate it, you know, let's draw an ABG in an hour or two and just see what, you know, what's going on. For something like that, they may or may not end up intubated. It just depends on certain things like their chest x-ray and fluid balance and things like that. So number 9, patients developed ARDS is placed on a rotoprone bed as a means of treatment. Their last ABG was that. On those vent settings, what should we do? I actually had a patient similar to this. We ended up having to push the PEEP up to 15 and the I time or to around 2.8. They didn't think it was going to work. Well, guess what? It did. And we were able to wean down FiO2, and you could notice a difference in the chest x-ray. So the same patient, next morning, there's the new ABG and the new vent settings. Patient stable. What would you like to do for this patient? So we do a couple of things. Increase the delta and the I time to help with oxygenation and ventilation. With ARDS patients, you know, per ARDSNet protocol, it is okay to allow for permissive hypercapnia. If you want, you can put them on bilevel to allow for some spontaneous breathing on top of what they're already getting from the ventilator, and that will help with ventilation. And you just kind of want to just make sure your peak airway pressures and your median airway pressures are acceptable in order to help prevent trauma to the lungs. These vent settings are, you know, not bad. And then, you know, you can do an ABG after a couple hours and wean the FiO2 as tolerated. So if a patient is in assist control and they're breathing 18 on a rate of 12, if I lower the rate, what bearing will it have on a patient's respiratory rate? And the answer is none, because you're allowing them to breathe over if they can. So if you want to, there's a couple of reasons why this could be the case, but you know, that's each patient's different. And then if you PEEP someone up too much, what does it do to their blood pressure? It can cause it to decrease due to tamponade. And then why do you want to monitor auto PEEP? It just shows that your expiratory time may be too short, although you can also use that to your advantage in ARDS situations for ventilator management. And then what's better to wean first, high PEEP or high FiO2? I always want to monitor FiO2 first and decrease it as tolerated. You want to try and limit the amount of free radicals being created from high FiO2s. And in conclusion, I hope this was informative. And if you have any information, you know, and I can make it better, I'm always willing to listen. And also, you know, critical care people, they have a million different ideas on how to manage vents. I did this based on how I was educated at Santa Fe here in Florida, and both doing trauma and critical care medicine from two different groups of physicians. So if you say, well, our trauma team, yeah, I know trauma just kind of does their own thing and critical care is going to do their own thing. I've noticed a difference between a trauma doc versus a intensivist with a pulmonary background, so it's no secret. Alright, thank you for viewing my video. Feel free to hit subscribe and look at some of the other content I have posted. MediocreRRT is my email, and I hope this video helps you on your journey to become a better respiratory therapist. Thank you very much.